So now that we've gone over all the components, the next question that should come to your mind is, how are we going to pay for all of this? The Congressional Budget Office, or CBO, says that in the long run we'll probably end up saving money, saying that we'll be getting in about $803 billion and paying out about $604 billion for a total savings of around $210 billion. And this estimate was made before the Supreme Court decision, and the Supreme Court decision said that states can opt out of the Medicaid expansion, meaning that there are going to be some states who are not going to be taking federal money, meaning we'll be putting out less money, maybe $84 billion less money, so we might even save more money. So what are this input of money, where is that coming from? So this is going to come from a whole bunch of different places. The first thing is higher Medicare taxes on the wealthy. So this amount used to be 2.9%, and that was split between the employers and the employee, and that's now going to go up to 3.8%, and that's going to be on anyone who is making more than $200,000 a year, or couples that are making $250,000 a year. So this will actually not affect necessarily the wealthy, but a lot of middle-class people as well. Health insurers are also going to be hit with a tax, as are importers of prescription medications and medical device manufacturers will be too. And those people who get the so-called Cadillac plans, and those are plans that cost about $10,000 a year in premiums for a person, or $27,500 for a family. So they would also get a 40% tax. Now, it's conceivable that you would pay this much for a family. This is not that huge a number, and 40% is kind of a big tax. Then, of course, there's that money from the young, healthy people who decide that they don't want to get the insurance, and so there's the penalties. That tax also. And one of the stranger ones, at least I think is strange, that there is a 10% federal sales tax on anybody who uses tanning services. I wonder what John Boehner thinks of that one. Some other ways that money will be saved. Medicare Advantage, that'll be gone. Something called dish payments will also be gone. Dish payments, let me explain that. That's called disproportionate share, so D-I-S-H, dish payments. And that's the money that the government would pay to hospitals to subsidize uninsured patients that were coming in. And so now technically we'll have a lot less uninsured patients, so there's less need for these dish payments. Also, fraud, waste, and abuse, they think, will be gone. And so that will save money. And as an example of one of these ways that we could save money with waste is right now every insurance company has a hospital fill out a different form. And so they got to fill out many different kind of forms, each one being complex. And they're going to recommend that we have a universal claim submission form. And that doesn't sound like much, but the hospitals spend a lot of money just on filling out paperwork. So if we could make that cheaper, why not? So this is just some of the ways that it can save money. Let's go look at some things in a bit more detail. The first is quality over quantity, quality over quantity. And so the way the current system works in our fee-for-service model, you get paid for everything that you do. So let's say you do a colonoscopy, you get paid for that colonoscopy. If you do 2, then you get paid for 2 colonoscopies. But the outcomes don't really matter. Let's say the person gets treated, but then they have a horrible outcome and they have to stay in the hospital. So now you not only get paid for the colonoscopy, you also get paid for taking care of that patient in the hospital. So that wasn't necessarily good quality. So we would establish something called the CMMI, or the Center for Medicare and Medicaid Innovation. And this organization would be responsible for creating pilot programs to see what works on a small scale before rolling it out to a big scale. Accountable care organizations. And these ACOs are groups of hospitals and clinics that are accountable for the cost and quality given to a particular population. and they would be given money for for a particular procedures that were done. They were given money. They're given money to take care of an entire population. Now, this is different, really, than HMOs. Their job in the past, like in the 90s, if you can remember, was simply to cut costs, and the way they cut costs was by denying care. Now, these accountable care organizations, they want to cut costs, but they also have to improve quality. So that's the difference. The reason people hated the HMOs is because they just denied care, and so nobody could see their doctor, nobody could get anything that they wanted done, and yes, it was cheaper, but it wasn't very good. Now, bundling of care is where a group is going to collaborate to provide care. So let's say someone's getting a hip replacement, so the orthopedists, the physical therapists, the anesthesiologists, the medical doctors, the occupational therapists, the phlebotomists, all of them are going to be given one lump sum for doing the hip replacement. And if they're able to do it in a way that is quality and cheap, then they get to keep the savings that they get. If for some reason there are a lot of complications and it comes out costing more, well, then they don't get paid more. They get paid that one lump sum, and that's it. And so there's incentive there for people to find quality ways to lower the cost. Another thing is patient-centered outcomes research. And this institute, PCORI we call it, would perform comparative effectiveness research, really asking what works better, which treatment works better, what ends up having better outcomes, and also which one is cheaper. Now, we know that we spend way more money at the end of life than we do at the beginning. So we know that we end up spending a lot more money on old people than we do on the younger people. And so this is where the term death panels came from. People were afraid that we were going to find out that the research says it's too expensive to keep grandpa alive, so let him die. And so this got a lot of negative press, and because of this, the CMMI is going to support patient-centered outcomes research. However, it is not going to be allowed to have any impact on premiums or care delivery. But doctors could look at this and say, this therapy was cheaper than this one. I'm going to use this one because I want to make more money. If I save more money, I get more money. And so the docs can use this comparative effectiveness research. We just can't, the government can't use it for rationing of care, or it can't be used for mandates or anything like that because of the whole death panel scare that we had before. It really isn't about death panels. It's really just about finding out what is cost effective and what has good quality. But this is how the media portrayed it, so that this is where we are. We will also have audits that can be used to save money. And so right now there's something called PQRI, which is the Physician Quality Reporting Index. And right now, doctors get paid money just for reporting on certain measures, like how many of your patients lived, or how quickly did you get antibiotics to your pneumonia patient, or how quickly did you get your patient to the cath lab. Those sorts of quality indexes, those things are reported. And for right now, you just get paid for reporting it. But in the future, in 2017, they're going to actually say, if you don't do well on these things, we'll take money away from you. And then they'll eventually be reporting this on a website, your quality versus your cost. And if you give high quality care and you give low cost care, so we got high quality but low cost, you will get a bonus. But if you give low quality care at high cost, then you're going to get a penalty. So now the incentive here is going to be to give high quality and low cost. So you can see this is one of the indirect measures that this would be using to decrease costs. And if this stuff is published on a website, anyone can go online and shop around for doctors. They can shop around for the ones that give quality care at a cheaper price. So competition is going to hopefully increase quality and decrease costs. Additionally, the designers of the Affordable Care Act looked at who are the people who provided quality care and cheaply, what are some of the factors that they had in common, and one of them was the use of computers, healthcare IT, meaningful use, not just using technology for technology's sake, but using it in a way to decrease costs. So that's why people who would use e-prescribing or electronic medical records would also get some money, but with the hope that this would decrease costs. One more method that would be used to try to lower cost is the replacement of something called MedPAC with something called IPAB. Let's talk about that. So MedPAC is the Medicare Payment Advisory Council, and this is a group that is supposed to advise Congress on how to decrease Medicare spending. Now, the problem with this system is it literally takes an act of Congress to lower Medicare spending. We know that they don't tend to do things very efficiently. And that's actually what we found, is that there have been things that MedPAC had suggested that would decrease costs that Congress had not adopted, and they had even continued to do things on their own that might have not been cost efficient. So healthcare economists, people like Uwe Reinhardt, say, you know what, this MedPAC is not an efficient method for lowering costs, and they are really beholden to special interests through Congress, and so these guys are really ineffectual. So why don't we replace it with IPAB, which is the Independent Payment Advisory Board. The independent is the important word here, because you don't advise Congress, they're able to decrease Medicare spending on their own. So they get rid of the middleman. So this would be 15 people appointed by probably President Obama who would have special knowledge, special expertise on healthcare policy. And so they would be the ones who would be decreasing Medicare spending. Now, people were afraid that these guys are going to ration care, and they would be the real death panels. Though there is specific language in the Affordable Care Act saying that they do not have the ability to ration care. They only have the ability to set payments, to set the growth rate for premiums. And so they won't tell you what you can get, they can just tell what can be charged for this. And so this portion itself has been the subject of many, many attempts to repeal it, because people are afraid that this is going to really decrease the amount that's going to be paid to doctor and affect care that way, because care will not be reimbursed properly. So this was just one quick look at the many different aspects that are going to be used to try to save money and raise money for the Affordable Care Act. And according to the Central Budget Office, this will actually work. They say that we will save money, but this is a pretty complicated system. And so you could see now why the Affordable Care Act, given all the stuff that's in it, is 900 plus pages in length. So this concludes my overview of the Affordable Care Act. Obviously, each one of these things has details within it, but I think we should understand what's in here and why it's in here, so that we can have an intelligent conversation, an informed conversation. Whether you're for it or whether you're against it, we should understand it before we talk about it. Okay, have a good day.